Dear colleague, welcome to the March live webinar brought to you by the Cytokine Signaling Forum. Thank you very much for supporting us and for submitting questions prior to the meeting. My name is Laishan Tam. I'm a rheumatologist from the Chinese University of Hong Kong, and I'm extremely delighted to have Professor George Kitters with me today. And George is a consultant rheumatologist from the Dudley Group NHS Foundation Trust. So these are our disclosures. And oh, sorry, George, would you like to say hello to our audience?
Yes, hello everybody. Thank you very much for joining us. I hope we will have a good presentation, a good session, and some good question and answers towards the end. Thank you.
Thank you very much, George. So these are our disclosures. So just a few housekeeping issues. So the attendees will be on mute for the duration of the meeting. So in case you have questions for us, please submit anytime during the meeting through the Q&A function. If you have any questions or are experiencing any technical difficulties, please use the chat box. So this is the agenda for today. So after the introduction, I will start my presentation on inflammation and accelerated atherosclerosis. How can we diagnose early? And then followed by the talk by George on the effect of biologic bDMARDs on cardiovascular risk in patients with inflammatory rheumatic diseases, and followed by the Q&A session. Okay, so let's start with the first presentation. So the objective for this talk is to familiarize the audience with the role of inflammation in accelerating atherosclerosis in patients with inflammatory arthritis. And you can see on the right-hand side, the atherosclerotic plaque actually quite similar to the pannus with the infiltration of the inflammatory cells. So actually, atherosclerosis is an inflammatory disease, and that's why we need to understand a bit more about how inflammation accelerates atherosclerosis in our patients. So I'm going to start with the prevalence of cardiovascular diseases in patients with inflammatory arthritis, and then I'm going to talk about the risk factors associated with accelerated atherosclerosis in these patients, and then we will discuss what should we do in the clinic, followed by a summary. So I'm sure the audience are all familiar with the increase in cardiovascular disease in patients with rheumatoid arthritis. And there are in this study, a systematic review, including more than 90,000 patients, cardiovascular disease accounts for more than 40% of deaths. And also, when we look at two meta-analyses, one of them reported a 48% increase in risk of cardiovascular events. And then the other looking at more than 100,000 patients, reported that in patients with rheumatoid arthritis, there's actually a 50% higher cardiovascular related mortality compared to the general population. Indeed, this is not only limited to patients with rheumatoid arthritis, and actually similar population-based study have reported increased cardiovascular risk in patients with RA-AS and psoriatic arthritis as well. So all of these patients with inflammatory arthritis has increased risk of myocardial infarction, cardiovascular mortality, and morbidity. So you might ask, is it because they have a higher prevalence of cardiovascular risk factors? Indeed, this is true. So this is a recently published meta-analysis in patients with axial spondyloarthritis. And you can see that, So on the right-hand side, there is indeed an increased prevalence of hypertension, diabetes, and hyperlipidemia, which accounts for 13.5% to 22% in these patients with axial spondyloarthritis. And again, this is not just in patients with axial spondyloarthritis. Sorry. Patients with rheumatoid arthritis as well as psoriatic arthritis are also having increased prevalence of cardiovascular risk factors. However, even if we have adjusted for the cardiovascular risk factors, they still have an increased prevalence of cardiovascular events. And why is this? Well, it's because these patients have systemic inflammation. So what really happens is that the pro-inflammatory cytokines, including TNF-alpha, IL-1 beta, IL-6, released from the joints, can actually lead to arterial wall inflammation, endothelial dysfunction, increasing arterial stiffness, leading to atherosclerosis, and ultimately increase the unstable coronary plaques, and then cardiovascular events. And they have also these pro-inflammatory cytokines can also lead to other systemic effects. For example, in the skeletal muscle, it will inhibit the reuptake of sugar into the muscles, leading to decrease in functional capacity of the muscle, insulin resistance. And in the, it can also alter the lipid levels and also lipid particle composition in active disease. And in the adipose tissue, it can alter body composition, leading to increase in central fat deposition, as well as a reduction in lean mass. And for example, IL-6 will lead to increase in CRP production, as well as increase in synthesis of coagulants, such as fibrinogen, leading to a hypercoagulable state. So all these together will lead to increased prevalence of cardiovascular diseases. But then each disease has also its unique feature. For example, in our patients with psoriatic arthritis, you can easily notice that they are obese, they tend to have increased blood pressure, non-alcoholic fatty liver disease, and dyslipidemia. Although they might have a little sort of a low-grade inflammation compared to the high-grade inflammation in patients with rheumatoid arthritis, and their metabolic phenotypes tends to be they tend not to be obese, but they actually have sarcopenic obesity with fat infiltration into the muscles, as well as a increased insulin resistance. How about patients with spondyloarthritis? And we all know that IL-17 plays an important role in the pathogenesis, and actually in the endothelial cells, as well as in the vascular smooth muscle cells, it can work together with TNF-alpha and interferon gamma, leading to release of pro-inflammatory cytokines, chemokines, adhesion molecules, and lead to and also plaque destabilizing proteins, resulting in leukocyte recruitment, inflammation in the blood vessels, and ultimately lead to plaque vulnerability. However, IL-17 can also lead to collagen deposition in the vascular smooth muscle cells, which actually can help stabilizing the plaque. So the role of IL-17 at this moment is actually rather controversial. So I hope we are all familiar with why these patients have with inflammatory disease have accelerated atherosclerosis. So the key question that definitely would be whether suppressing the inflammatory pathway can prevent cardiovascular events. And indeed, this has been demonstrated in patients with a history of myocardial infarction in this CANTOS study published in the New England Journal of Medicine a few years ago. So these are patients with a history of MI and an increase in a high sensitive CRP, and they were randomized to receive IL-1 blocker. So you can see this is the cumulative incidence of the cardiovascular events, the primary outcome. And after adjusting for other confounding factors, canakinumab at a dose of 150 milligrams every 3 months can lead to a significantly lower rate of recurring cardiovascular event than placebo. And notice that there was a dose-related reduction in the high sensitive CRP indicating that there is a significant reduction in inflammation, whereas the lipid level was unchanged. So this is independent of lipid lowering. Now, what is happening to our patients with inflammatory arthritis? I will let our next speaker, Professor Kitas, to discuss with you in further details. So, so what should we do? So actually, EULAR has published this recommendation, and Professor Kitas is one of the authors. So if you have any questions, please feel free to ask him in the Q&A session. EULAR actually suggests we should assess the cardiovascular risk of our patients at least once every 5 years. So according to the national guidelines. So I don't know whether which risk score are you familiar with. So I'm more familiar with the Framingham risk score. Perhaps our audience from the Europe are more familiar with the score. So let us just take a look at my patient, who is a psoriatic arthritis patient. He's now 45 years old, and he was diagnosed psoriatic arthritis 10 years ago. And he also had dyslipidemia. And he's now complaining of non-specific chest discomfort, and the ECG at rest didn't show any ischemic changes. So I look at the Framingham risk score here. He's a male, 45, smoker. Lipid profile was normal, systolic blood pressure okay. He hasn't been treated with any anti-blood pressure medicine. So the score was 9.3%. So if you strictly adhere to the classification, this is low risk. And then, so is it really true that this patient has low risk? So in these kind of patients, what advice would you give? So definitely we would aggressively counsel against smoking, exercise, weight, diet, etc., and manage the blood pressure, but it's normal. And how about statin? So would you consider giving statin in this patient? So before we give statin, let's take a look at whether statin is effective in preventing morbidity in our patients with inflammatory arthritis. So this is a study published a few years ago, looking at, this is a population-based cohort study in patients with ankylosing spondylitis. So in a propensity-matched cohort, you can see that the statin users have a 37% reduction in all-cause mortality risk. And similarly, our Professor Kitas have also performed a study in patients with rheumatoid arthritis. The TRACE-RA study published like 2 or 3 years ago, and also reporting a 34% reduction in cardiovascular events in patients with rheumatoid arthritis. So I think all of us are quite convinced that these patients, the statin is equally effective in our patients with inflammatory arthritis in preventing cardiovascular morbidity and mortality. So what is the problem with this cardiovascular risk score? It's been reported in patients with rheumatoid arthritis as well as in psoriatic arthritis that these risk scores underestimate the cardiovascular risk because they did not take into consideration inflammation. So EULAR actually recommends a 1.5 multiplication factor for rheumatoid arthritis patients. And so we did a study in our patients with ankylosing spondylitis, 463 patients followed for 12 years. And on the left-hand side, you can see no matter which score you're looking at, the black column are the observed events and the gray column are the expected events. So you can see this risk score mostly underestimated the cardiovascular events. Even after applying the EULAR multiplication factor, you can still see that this did not increase the accuracy in predicting cardiovascular events. So what should we do? EULAR actually suggests that we might consider doing high-resolution ultrasound and look at the blood vessel directly. So for some of us who are using musculoskeletal ultrasound, it is actually not difficult to do. So you just change to a vascular probe, and then you can actually do it in half an hour. So on the left-hand side, you can see the very nice thin layer of the intima as well as the media. So this is what we like to measure, the intima media thickness. Whereas on the right-hand side, you can see the intima and the media layers are all thickened, and you can also see this protrusion here indicated by the red arrow showing a carotid plaque. And the presence of plaque is actually indicating that this patient has high risk. And we have been looking at this in our patients with psoriatic arthritis. And when we look at whether the mean or the maximum carotid IMT, so in our patient with psoriatic arthritis with or without cardiovascular risk factor, the intima media thickness is significantly increased, suggesting that PSA is associated with subclinical atherosclerosis, even adjusting for traditional cardiovascular risk factors. And this is, again, also true in patients with rheumatoid arthritis as well as in patients with ankylosing spondylitis. So why is that important? As I have mentioned to you earlier on, so we have been following these 154 patients with a baseline high-resolution ultrasound carotid done, and when we divide them into those with a baseline presence of carotid plaque in the green line on the right-hand side, compared to those without carotid plaque presence at the in the purple line, you can see those with a baseline presence of carotid plaque as a significant increase in cardiovascular events in the next 10 years. And on the left-hand side, you can see even adjusting for the disease activity as well as the baseline cardiovascular risk score, the hazard ratio of having a cardiovascular event increased 2.4 to 3.4-fold in these patients with the baseline presence of a carotid plaque. And again, in patients with rheumatoid arthritis, this is also quite similar with a 2 to 3-fold increase in cardiovascular event rate. And in fact, this is not just, the subclinical atherosclerosis was not just limiting to the carotid vessel. And when we, look at 90 PSA patients without cardiovascular disease and subject him to do a coronary CT angiogram, compare with 240 age, sex, and cardiovascular risk factor matched controls, we were actually quite surprised to see that they have a 60% prevalence of subclinical coronary atherosclerosis, a prevalence increased twofold compared with the matched controls. And it is also, whether when we're looking at the high-risk plaque, including the mixed plaque and non-calcified plaque, the prevalence is also increased 2 to 3-fold. So this is actually quite alarming, suggesting that a lot of our patients are having silent coronary ischemia. So that's why, as their physicians, our rheumatologists, should be really vigilant in finding these high-risk patients and manage them aggressively and early. So back to our patients with a Framingham risk score of 9.5. So because he was actually part of the research subject, so we performed a carotid ultrasound on him. So the carotid IMT was slightly increased, but we found a plaque in the right bulb region. So if this is your patient, what would you do next? Would you just give statin, or would you perform a coronary CT angiogram, as I alluded to earlier on, or would you just refer the patient to see cardiologist? So again, because this patient is actually part of our research cohort, so he was subjected to a coronary CT angiogram, which surprisingly revealed triple vessel disease with a calcium score of greater than 1,000. So he was diagnosed to have ischemic heart disease, and he was referred to the cardiologist. Of course, we started him on aspirin and statin, and then a month later, he had a coronary angiography and percutaneous coronary intervention on the left anterior descending artery, and he was treated with clopidogrel for a year. So he was really grateful that we have recruited him into the trial and sort of saved his life. So much so for the cardiovascular screening. So actually, if you look at the EULAR recommendation, the first recommendation is actually to treat inflammation aggressively in order to lower cardiovascular risk. So is that true? And so we have also looked at the disease activity in our psoriatic arthritis cohort, and when the baseline disease activity was high, according to the DAPSA, as indicated by the purple line on the left-hand side, you can see the cardiovascular event is actually much higher than, significantly higher than those with a low or moderate disease activity at baseline. And when we look at patients with early RA, this is an early RA cohort from the Netherlands. So when they look at the time average disease activity score, those with a low disease activities, as indicated in the green line, have a significantly lower cardiovascular event rates compared to those with moderate and high disease activity. So the rheumatologists are really important, play a really important role in managing, so treating this patient to target not just relieving the joint symptoms, but we are also hopefully will prevent long-term cardiovascular morbidity. So I can't emphasize more the role of lifestyle recommendations, diet, exercise, smoking cessation, and then we've also talked about statin use. Last but not least, about NSAIDs. So looking at this meta-analysis, I mean, you can see that as a whole, NSAIDs carries an increased risk, but actually is all related to rofecoxib, which has been withdrawn. So if we take it out, actually NSAIDs, COX-2 or NSAIDs are not associated with increased risk. In fact, there are evidence suggesting that the non-exposure of NSAIDs in patients with ankylosing spondylitis and rheumatoid arthritis was associated with increased cardiovascular events, and we've also looked at the PSA population, and we have also found similar results. So in summary, ladies and gentlemen, I'm sure you will agree with me that in patients with inflammatory arthritis, they are at risk of premature atherosclerosis. It's because systemic inflammation interacts with the metabolic risk factors leading to initiation and progression of atherosclerotic process. So effective suppression of inflammation and treatment of cardiovascular risk factors may prevent progression of cardiovascular events, and we should also consider aggressive statin therapy in patients with high cardiovascular risk. So thank you very much for your attention. And now I would like to introduce our next speaker, Professor George Kitas. So Professor Kitas has published extensively in the field of cardiovascular rheumatology, and that's why he's here today. And he's the convener of the BSR Cardiovascular Special Interest Group. And as I mentioned, he's a member of the EULAR Task Force for Cardiovascular Risk Management. And he's also the principal investigator of the TRACE-RA study on the effect of statin in rheumatoid arthritis. So without further ado, may I call upon George to deliver this talk to us on entitled The Effect of Biologic bDMARDs on Cardiovascular Risk in Patients with Inflammatory Rheumatic Diseases. Professor George Keatis, please.
Thank you very much, Lai-Shan, and thank you to the organizers for inviting me to contribute to this seminar. What I will try to cover in the next 20 minutes or so is the effect of biologic bDMARDs on cardiovascular risk in rheumatoid arthritis and in the spondyloarthropathies, and try to summarize and come to a conclusion. Just to sum up what Lai-Shan has already said, in our patients, we have to deal with various risk factors. Some of them are not modifiable. We cannot do anything about people's age, sex, family history, etc. And the same applies in our patients for other risk factors, for example, the presence of some autoantibodies. But then there in the middle, we have all of the modifiable risk factors, which have just been mentioned. And I would like to emphasize inflammation as one, and the therapies we use for inflammation as another. And this is what these two is what we are going to be concentrating on in the next few minutes. Also, I would like to emphasize again that we have two main aspects in our armamentarium on cardiovascular risk management in the general population and in our patients. One is lifestyle modification, and the second is drugs. And in my opinion, the correct sequence of them should be one, lifestyle modification, and two, pharmacological therapy. And we tend to forget this, not only us as rheumatologists, but generally in all medical specialties, we pay much more attention to drugs. And this is what we are going to do today again, but please don't forget lifestyle modification. So when we talk about pharmacological management, again, I will start from the right side of this slide. We can use many different therapies to control classical, let's say, cardiovascular risk factors. And we may need to use lipid-lowering agents, as Lai-Shan has already mentioned, antihypertensives, drugs for glycemic control, and these are continuously increasing. These are areas which in themselves are evolving all the time. To be honest with you, I have stopped trying to figure out what we can use for glycemic control in the general population, because literally every day there are new agents coming out. So it is possible that for this aspect of treatment for our patients, we may need increasingly to use the expertise of colleagues. But this part here, which is the use of anti-rheumatic drugs to control inflammation and improve the outcome of our patients, is firmly in our hands. And biologic bDMARDs is one of the main areas that we have been using in the last 20 years very successfully. Now, we do not need EULAR or other recommendations any longer to tell us that early and complete control of inflammation is the main objective of our management of a patient as rheumatologists, because the evidence has been there and always keeps increasing that effective control of inflammation improves outcomes tremendously. We don't see patients like this any longer to be able to show them to our students. And why is that? Because we have better strategies and better medications to used in these strategies to control inflammation. And controlling inflammation effectively does have an effect, it appears, on improving cardiovascular outcomes. The problem, however, is that now we have an awful lot of options, an awful lot of drugs to choose from in trying to control inflammation in our patients. We are nowhere near advanced enough to be able to say that drug X is superior to drug Y or Z for patient A or B. And we need to find ways to try, with whatever means we have, mostly our experience, I suppose, to choose the right drug for the right person at the right time. I'm not going to discuss again the role of cytokines in cardiovascular risk. Lai Shan has covered this using the same slide. So let's move directly to interventions. Now, when we assess any type of intervention on cardiovascular risk, we may be talking about 4 different things. One is the effect of whatever intervention on specific risk factors, for example, blood pressure, lipids. The second is the effect of whatever intervention on surrogates of cardiovascular disease. For example, FMD, which assesses endothelial function, pulse wave velocity, which assesses arterial stiffness, IMT, which has already been mentioned, which assesses atherosclerosis. And they are not necessarily the same things. Indeed, they are not the same things. Then we may be talking about the effect of interventions on cardiovascular events, for example, heart attacks or strokes, and the effect of interventions on cardiovascular death. The level of evidence we have is unfortunately an inverted pyramid. We have thousands, literally, of studies assessing the effect of drugs on risk factors, hundreds of studies assessing the effects of drugs on surrogates, very few studies assessing the effect of drugs on cardiovascular events, and most of these studies are observational studies. So the level of evidence, if one wants to look at it in a very hard scientific manner, is actually relatively poor. Let's go systematically now through some of the studies that have been done and what they've shown. As I said, there are thousands. I've just selected some. So if we consider the effect of anti-TNFs in patients with rheumatoid arthritis, in terms of cardiovascular risk factors, that is blood pressure, cholesterol, and surrogates, we do in general see advantageous effects. So the cholesterol profile roughly remains the same. Some studies show X, some studies show Y, but roughly it's the same. LDL is not affected adversely. And there are some studies showing improvements in blood pressure control. And generally, the studies that have been done on surrogates show improvements by using anti-TNFs. Most of these studies are, as I said, observational. Some of them are not even controlled. If we look at the effect of anti-TNFs on myocardial infarction, again, these are predominantly studies that come from registries and long-term observation, which by design have some disadvantages. But again, generally, with anti-TNFs, we see an improvement in outcomes compared to people who have not received biologic therapy. This is from the BSR, the British Registry. And we see a reduction in MIs in the region of 40%. Now, if we look at another registry, another database, which is the Australian Rheumatology Association database, and look at the effect of anti-TNFs, or the associations, I should say, of anti-TNF treatment with cerebrovascular events. Again, we see that those people who use anti-TNFs appear to have less cerebrovascular events, in the region of about 15% less. Those who use other biologic therapies also the same, about 20% less. But this effect does not appear to be present in patients who stopped taking biologic therapy for whatever reason. And in this study, there do not appear to be any significant differences depending on the type of inflammatory disease you have. So people with rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis appear to be behaving in the same way. Again, this is now a meta-analysis for cerebrovascular events, and you see the bottom line is roughly 30% reduction in the risk for a cardiovascular event using anti-TNFs in patients with rheumatoid arthritis. And some other analysis. Now, I should probably point out one thing which is quite important, and this is that virtually all of the studies of the anti-TNFs do not contain patients with congestive heart failure, or enough of them. And the reason for this is, of course, because the very early studies of etanercept and infliximab in heart failure were perceived to show negative effects. So there aren't simply many patients with heart failure who have received these agents. Now, for other biologic DMARDs in rheumatoid arthritis, the data is even less. It's mostly on surrogate markers. And again, the results are similar. There appear to be benefits. Now, as I said, when we have a lot of options, we should ideally be able to figure out whether option A may be better than option B, because we have a lot of drugs now which can very successfully suppress inflammation. Again, the evidence for this type of approach is extremely limited. There are very, very few studies that could inform such therapeutic decisions. This is one study of abatacept versus TNF inhibitors based on the Medicare and market scan databases in the United States. The primary outcome was a combination of heart attacks and strokes, and it appears that abatacept may be even better than TNF inhibitors, in that the hazard ratio was 0.8, and we already accept that TNF inhibitors are good. It's interesting that this appeared to be the case for people who had cardiovascular disease at baseline, and not in people with arthritis who did not have cardiovascular disease at baseline. Now, we all know about tocilizumab and its effects it appears to have on lipids, which appear to be more pronounced than other drugs. But it is interesting to remember that not everything that meets the eye tells us the truth. So an increase of lipid levels per se does not necessarily mean a bad outcome. For example, with tocilizumab, there is some very interesting data that shows that it changes lipid composition towards a more anti-inflammatory phenotype. And despite these absolute changes we observe in lipids, it does not appear to associate with a worse cardiovascular outcome. In fact, it appears to associate with improvements in cardiovascular outcome, again, from several studies. And again, based on the market scan and Medicare databases predominantly, there has been a comparison between tocilizumab and abatacept, which shows actually a better effect of tocilizumab than abatacept. So when we talk about biological DMARDs in rheumatoid arthritis, they do appear to have differential effects on some cardiovascular risk factors, predominantly lipids. They appear to improve surrogate markers of cardiovascular disease, and they do associate with improved outcomes. I am not personally convinced that we have sufficient evidence to say whether X class of biologic is better than Y class of biologic, even on average, let alone in a particular patient. But I think we can be reasonably confident that tocilizumab is not worse despite its more pronounced effects on lipids. And I must say again that most of the data is exclusively from observational studies and registers, which of course limits our ability to be confident about what we say. Now let's move to the seronegatives, and I will move very quickly through here. In fact, I will not discuss any slides in detail because we have the absolute expert in the world with us, Professor Tam, and you can ask her any questions about the effect of biologics in seronegatives. But the bottom line, again, if we look at the anti-TNFs, is that they appear to improve both some risk factors and surrogate markers. I would like to emphasize this study, which is one of the few well-designed studies, and this is a study by Professor Tam's group, assessing the effect of anti-TNFs on surrogate markers, specifically IMT, in people with psoriatic arthritis. And again, I think possibly she could tell us how she interprets this data. The way I interpreted this data, I must say, is that it appears that the effect of a good anti-inflammatory treatment, in this case anti-TNFs, associates with how early you use it. The earlier you use it, the better it is, and not necessarily on the duration, but this is something that we could possibly discuss later. The data on clinical outcomes is even more limited in the seronegatives than it is in rheumatoid arthritis. But again, anti-TNFs appear to improve outcomes in terms of myocardial infarction. And roughly in the same region, about 20–30%, as we see in people with rheumatoid arthritis. Now, what is very interesting in the spondyloarthropathies is that we have biologics which work through completely different pathways. And there we see some things which are actually relatively difficult to interpret. For example, what we would expect to see with IL-17 or IL-12/23 inhibitors from their in vitro effects, which appear to be anti-atherogenic, does not appear to be happening when we use them clinically, in that they do not appear to be so protective. In fact, MACEs appear to be occurring more frequently with IL-17 inhibitors, for example, and IL-12/23, but not with apremilast. And the same in psoriasis appears to occur with IL-23. So there is actually quite a lot of work to be done there to understand whether this is a true phenomenon and what it is based on. And this is something that we can discuss with Professor Tam afterwards. But again, to summarize the clinical data we have, biologic DMARDs, particularly the anti-TNFs, improve surrogate markers of cardiovascular disease in seronegative patients and associate with better cardiovascular outcomes in terms of myocardial infarctions and cardiovascular events. Again, the data is almost exclusively from observational studies and registries, and it's even less studies than we have in rheumatoid arthritis. And this area here is, I think, an area that we need to do much more work to understand what is happening in the clinical arena, and even more to understand whether there may be differences and why are there such differences in the different classes of biologics. So in general, the overall conclusions are that cardiovascular disease remains an important comorbidity and cause of death in people with inflammatory rheumatic diseases. Systemic inflammation and its direct or indirect effects on cardiovascular risk factors in the vasculature plays an important role. Sufficient control of inflammation improves outcomes, both in terms of cardiometabolic risk profile, vascular function and morphology, and clinical cardiovascular outcomes. But there appear to be important differences between different types of biologic DMARDs, and as we have very recently found out, TS DMARDs, and between different types of inflammatory diseases that require further investigation, and we must at some point in the future be able somehow to choose the right drug for the right patient, individual patient that we have in front of us. And the quality of evidence is generally poor, and this needs to be improved. Having said that, it is actually extremely difficult, possibly impossible, to do properly controlled, randomized controlled trials in people with inflammatory conditions comparing biologic A to biologic B, because the numbers required are really massive. So this is a very big challenge. We need to think of ways to address it. Thank you very much. I would like to thank my various research fellows and collaborators over the years. Thank you.
So thank you very much, George, for this comprehensive review. And so I guess we would like to take some questions. So we have two questions here. So the first question is, if aspirin is recommended for cardiovascular disease, why NSAID would exacerbate cardiovascular disease? So I guess I will take this one. It's actually because the COX-2, mainly the COX-2 inhibitors, they lead to an imbalance between the prostaglandin I2 production by the vascular endothelium and the thromboxane A2 by the platelets, therefore resulting in hypertension and atherosclerotic plaque destabilization and a prothrombotic effect. So in general, we actually thought NSAID carries an increased risk. But then actually, as I've briefly mentioned, in patients with inflammatory arthritis, is actually the lack of exposure of NSAIDs was actually associated with increasing cardiovascular events in patients with rheumatoid arthritis and ankylosing spondylitis. And recently, we also demonstrated that in patients with psoriatic arthritis. So I guess the inflammatory arthritis population is different from the usual osteoarthritis, patients who are also on long-term NSAIDs, but I guess because, I don't know, suppressing the inflammation may actually prevent cardiovascular events in patients with NSAID takers, or possibly, I don't know, perhaps these patients with high cardiovascular risk, as a rheumatologist, we tend to avoid the use of NSAIDs. So what do you think about this, George?
Well, I think that generally we should be using drugs carefully.
Mm-hmm.
I'm not so concerned about non-steroidals and coxibs as a whole.
Mm-hmm.
I don't mean to say that we should be using them freely, but I'm not as concerned as we were in the past. I think that they definitely have the potential to make some individual risk factors worse, particularly hypertension. They do have a hypertensive potential, some of them more than others, and it is something that we can monitor if we use them. Another issue which relates to the question of aspirin, which is important in my view, but apparently it disappeared from the literature and the interest now for several years, is that if people are taking aspirin for its antiplatelet effect, and then you give a non-steroidal on top of that, there are some non-steroidals, for example, ibuprofen, which can affect adversely the antiplatelet effect of aspirin. And timing is important in this respect. That was big news, I don't remember now, probably 10, 15 years ago, but we appear to have forgotten it. And there is very little work that has been done to confirm or refute this, but it is an open question whether we should be using aspirin and NSAIDs together, and if so, how?
Yeah, so there are still a lot of questions remain unanswered in this area. So the second question is, do we have any study on the effect of anakinra in the cardiovascular events of our patients with inflammatory arthritis? I'm not aware of any.
Yeah, not to my knowledge. But I must say I have not looked specifically. I would have seen something.
Yes.
But again,
so I guess,
this is a very interesting question because anakinra is not used so extensively. But if let's say we consider the effects of the CANDOS trial, it's probably the most relevant drug that we have used at some point in rheumatoid disease to see whether it has an effect or not.
Yeah, unfortunately, it's not effective in the clinical management of our inflammatory arthritis patients. So that's why I guess people are not so interested. And I think after the CANTOS study, people are actually looking at the colchicine, which is much cheaper and less toxic, and it also can prevent cardiovascular events in patients with inflammatory arthritis. So I guess we probably should also look at the effect of colchicine in our patients with gout as a prophylaxis for cardiovascular events.
Definitely, yeah. Yep.
Yeah. Okay. So, so George, I have a question for you. So we have talked about the screening and to give them statin, and we know that statin works in our patients with inflammatory arthritis. Should we just give statin to everyone?
Well, I think that this is exactly the same question as saying that should we give statins to everyone in the general population over a certain age, and I don't think we should. I think that many of our patients are at a sufficient level of risk to require a statin, but at least as many, if not more, are at very low risk, and I don't see the point of giving statins to everybody.
Yeah, So as a rheumatologist, I guess our job is make sure the inflammation part is controlled. And I think this is the main driving force why these patients are at increased risk of having cardiovascular events. Yeah.
That is correct. Of course, one could consider the anti-inflammatory effects of statins in general. I don't think that they are significant enough for the level of inflammation we see in our patients. Clinically.
Right. So after reviewing all these biologic bDMARDs, so would it affect your choice of treatment? For example, if you're seeing a patient with high cardiovascular risk, who is also having high inflammatory, high-grade inflammation in the joints. So would this, what would be the first choice of treatment for managing these patients?
My first choice of treatment would be the quickest and most effective way to control their inflammation. My personal choice and bias in a patient who is naive would be to start them on steroids despite the negative things that steroids associate with, and start them immediately on methotrexate in combination with hydroxychloroquine. This is, I'm talking about rheumatoid arthritis patients, with the aim of getting rid of the steroids literally within the first 4 to 6 weeks. And if I do not have sufficient control of their disease by month 3 or 4, with the combination of methotrexate and hydroxychloroquine and without steroid any longer, then I would add a biologic. Now, what biologic I would add, I do not think that I have sufficient information from the studies that have been done in biologics to be able to choose X over Y over Z, not only in terms of cardiovascular risk, but also in terms of efficacy for their rheumatoid disease. Most of the experience exists with anti-TNFs, and probably my default action would be to start with anti-TNF only because I'm more used to it, not because I think it has advantages.
Yeah, and it has been proven to be, effective with a 40% reduction in cardiovascular event rate anyway.
Yeah.
So who should be responsible to look after the cardiovascular risk in our patients with rheumatoid arthritis or inflammatory arthritis?
Yeah, this is a very difficult question because it depends on the different health systems and the setups that are available, which even within the same health system may differ significantly from region to region. I do not really know how things are in Hong Kong. I know very well how things are in Britain, and I know very well how things are in Greece and in Holland. And there are massive differences even within the British system. My belief is that we as rheumatologists are responsible for the management of our patients, not their rheumatoid arthritis, the patient as a whole. So I think that monitoring for cardiovascular risk is probably best placed in the hands of rheumatologists, because it is us who are changing drugs all the time, and they may have an effect on cardiovascular risk factors. Okay, so I think that we should be monitoring the risk factors. We should have a baseline knowledge of what to do, and beyond that, there is definitely help from cardiologists, metabolic physicians, general practitioners, etc., for the specific management if we are not able to handle other drugs like statins, antihypertensives, etc. But
yeah,
I think
I totally agree.
The monitoring should be us.
Yeah. See, because, we are probably those people who are most aware of this problem in our patients with inflammatory arthritis. So I guess we can just act as a team leader, just like you've mentioned, and then enlist the help of other experts. And I've also, enlisted the help from our rheumatologist nurses. And they have been, really good in, and really diligent in looking at, these cardiovascular risk factors. And they definitely could be an asset in helping us to, manage our patients as a whole, including the comorbidities.
I also happen to think that we rheumatologists are possibly the best remaining general physicians because we deal with multi-system diseases. The experience that I have from colleagues in other specialties, like the cardiologists, for example, are very firmly looking at the cardiovascular system and nothing else. We are good at looking at the kidneys, cardiovascular, lungs, everything really. So we are good doctors in general.
Yes, we like to manage the whole person, rather than just looking at the joints. Yeah, right. So, so do you have any questions?
I have a question for you. Yes, please.
Yeah.
And this is in the seronegatives. What do you believe about differences in the cardiovascular outcome sense between anti-TNFs and the, let's say, newer categories, IL-17, 1223, and
yeah, so I think this is a very important questions that you have, presented very nicely regarding the results that we have for now. So there seems to be, some differential effects suggesting that the IL-17 pathway may, play a role either destabilizing, the plaque or something. But definitely we need more data from, I guess, probably not from the control trials, but from the registries like we have from rheumatoid arthritis. We have a lot of long-term mortality or morbidity data from a lot of large-scale registries. And for now, I guess in the spondyloarthritis literature, we are still lacking these kind of long-term big data. So I guess we just need more data to inform us whether this is true or not. But the data for now is a bit controversial, I guess.
But on the basis of what we know now, would you, for example, have reservations about prescribing, let's say, anti-IL-17 in somebody with a high cardiovascular
risk? Yeah. Again, I guess, although we don't have a lot of evidence right now, but the choice of treatment is mainly, based on the clinical indication. And like you, I'm more familiar with the anti-TNFs, and unless there are contraindications. So I guess we will just have to discuss the pros and cons, and also let the patients know about the potential problems. But then the first choice to me is still probably anti-TNF unless there are contraindications. Yeah.
Thank you.
Okay. All right. So so I hope the audience have enjoyed this exciting webinar, as well as the discussions on the scenarios that we have discussed. And so this is indeed a very important issues that we need to focus our attention on, because actually, our patients are now definitely are not dying because of the joint disease, but they are still have a lot of cardiovascular comorbidities. And as a leader in the team of looking after patients with rheumatic diseases, I'm sure you and I are very much interested in how we can identify this patient early and how to manage the inflammation as well as the cardiovascular risk factor together aggressively in order to make sure that our patients have both good quality of life as well as decrease in risk of having comorbidities like cardiovascular events. So I would like to thank Professor Kitis once again for his excellent presentation. And I would also like to thank the audience for your participation, for your questions. And so please fill in the short evaluation form to let us know your feedback. And the live stream version of this webinar is now available to view on our YouTube channels, Cytokine Signaling Forum. So please also join us for the next edition of Forum Live, entitled Measuring RA in Practice, on April 6, 2022. So with that, I would like to end this webinar and wishing you all a very good day. Thank you. Bye-bye.